hospital will give you the medicine, it is still useful for us, no? We can combat these illnesses through a community managed or community-based health program. And I'm one person or in the public health that we really have to ensure that the community is being mobilized in terms of eradicating illnesses of public health importance. So even if you take medicine, especially for TB, have a community partner in order for the person to ensure that that person practice minimum public health protocols. You don't have to spit anywhere. So we still go for 70 to 80% of diseases are still preventable. Do you agree?
Yes, Doc.
Yes po, Doc.
Yes po, Doc. Yes po.
Okay. Akala ko wala akong kausap. Anyway, I will share my screen already. So now we go to a community-oriented primary care. The meaning and the scope when we say community-oriented and when we say primary care. See, this is the in right now because in the Department of Family and Community Medicine, it's not only on the hospital, but we really need that there will be primary care at all levels of care. In fact, with the universal health care coming in, we really have to ensure that there will be a primary care worker, not necessarily doctors, in the community. So health protection is increasingly seen as a responsibility of society and healthcare as a right of individuals. So the acute short-stay hospital with its various departments is regarded by many physicians, nurses, and other health personnel and the public as the center of healthcare. But there is now a shift, no? For us, we want to have a shift on this, that we will not be focusing on the curative, but on the preventive side. Yet its major functions are increasingly directed towards tertiary care. Much less attention has been given to developing the potential of healthcare in the community. So in our view, what is needed is a change in the orientation of practice and the practitioner. Just like, I will stop sharing first, just like what is happening right now in Tacloban, no? So all the Region 8 are experiencing spike of cases. You notice it, right? For COVID-19. In fact, right now, the problem with EVRMC is they are being bombarded with with asymptomatic and mild cases that should not be hospitalized. Second is, if you see the profile of those, there was a time we have how many cases for Tacloban? 112. 112, and everybody in the city of Tacloban is so panicky that they want to close Tacloban. Will you agree? Will you agree to to lock down Tacloban?
No. Yes.
Who is that? Doctor? Yes. Why do you say yes? Yes or no?
No.
Who answered that? Was it Dr. Santos? Will you lock down Tacloban and call for a timeout for all the hospitals? Dr. Bergamento. Sorry.
Lockdown, Doc, for the community, yes, but for the services in the hospitals, no.
How will you do that? I am in one GC that the doctors wanted a timeout. How can you have a timeout in the hospital?
Yes, Doc. There should be no timeout in the hospital.
Okay, so what would be What could probably be the one of the intervention? Dr. Howe, are you there? What could possibly some of the intervention of what we are experiencing right now? They have experienced it in Manila. They don't have beds anymore in Manila. That is Metro Manila. Ha? Metro Manila is the state-of-the-art hospitals. But eventually, what they have done? Dr. Howe? Yeah. What do you think we can do or some of our intervention in order to decongest the hospitals? Come on.
I think, Doc, it should be the proper utilization of primary and secondary referral system. That if the symptoms is manageable, then it should not be referred directly to the tertiary hospital for symptoms like fever and cough.
Did you notice I was not in the... Okay, so triaging is very important. At the same time is if you will see our data, no, 98.4 are mild and asymptomatic. Okay, because they are mild and asymptomatic, should they be in the hospital or not?
No, Doc.
My son is calling me. Yes. Can you? So, triaging and then AVRMCs should only receive the severe and the critical care. There is a panic mode that is happening right now everywhere in Region 8. So they, from as far as Catarman, because Catarman has a lot of cases, Calbayog has a lot of cases. So where are the referral hospitals? Dr. Chu, Marie, Dr. Chu, where are the referral hospitals?
Recording stopped. Recording in progress.
Dr. Chu, can you answer my question, please? Dr. Chu, can you answer my question, please? Yeah. Can you hear me?
You're down, you're right, you're not down. There it is, it's coming up now.
Yes. Can you hear me now?
Yes, Doc, can hear you, Doc.
Her microphone is broken. Can someone help her? Was it Dr. Noel? Okay, Santos. Yes, please.
I agree, Doc, with Dr. Bargamento that since the referring hospitals in Region 8 are here in Tacloban, siguro, na lang siguro, Doc, parang mas ma-intensify pa talaga yung intensify pa yung implementation ng paglimit ba ng unnecessary going out of the people na parang talagang na ano ba kasi we cannot hindi naman we cannot parang stop talaga the the operation of the hospitals here in Tacloban, considering that most of the
Recording
referring
stopped.
hospitals in the region.
Recording in progress.
I'm sorry. Dr. Santos, can you continue, please?
Doc, considering po kasi that most of the referring hospitals in Region 8 are here in Tacloban,
Recording stopped.
mahirap po talaga kasi na mag-stop yung ano. Siguro, kasi feeling ko, Doc, yung one of the reasons din na nag-increase dito yung cases kasi, di ba, for example, yung mga significant others na nababantay ng patients kasi hindi naman sila minsan na nasa swab or they become asymptomatic. So, parang unknowingly, parang siguro sila yung nakaka-ano, tas siguro pag i-intensify din yung implementation ng strict compliance to, yung parang ililimit lang talaga yung paglabas ng mga necessary going out. Siguro, yun po siguro, Doc, kasi we can still observe. Pero like here sa area namin, parang...
What about, taga saan ka, Dr. Santos?
Taga Katarman po, Doc, but I am currently living here in Katarman.
Oh, Katarman, ang dami. Inabayo tayo ng Katarman na cases, Northern Samar. We have a lot of cases in Northern Samar, and Katubig is the one with the variant of concern. Now, I think Dr. Mark, are you talking? Dr. Alleluia Mark. So if you notice, in a week's time, we have a spike of cases, but I am not accepting interviews. Why? Because in one night that we have 42 cases in EBRCTC, we have 34 out of 42 are healthcare workers. 34 out of 42 are healthcare workers. The next is another establishment, 42 cases. Another government establishment, they have a face-to-face thing. And so meaning, even though we have a lot of cases, they said that 98.4% are mild and asymptomatic. So meaning there must be, I agree with Dr. Santos, no, the significant others. Almost every hotels that we have wanted to come into Tacloban, but we don't have the resources anymore. They are using the address of Tacloban so they can access the hotel. They can access the RT-PCR. So meaning there is like a body, it's a system. So if the system fail in another municipality, you cannot say the system will not fail in Tacloban. And then we have the libreng sakay, no? Everybody wanted to, so if you go to it's not the time to go to malls right now. There are just so many people in the malls. Okay. And of course, we are relaxed in our protocol. We got so relaxed in our protocol, and I'm happy we don't have vaccination for the next 2 weeks because our vaccinators, I have the reason to postpone the vaccination because 3 of the vaccinators from the Department of Health turned out positive. I don't know for the next results of the RT-PCR test, no? And one government agency from, if you will appreciate now the epidemiology of COVID-19. It is highly infectious, but it is not deadly. So if you remember our lecture, the case fatality rate for SARS is 10, while the case fatality rate for COVID-19 is about 2 to 3, right? 2 to 3%. The case fatality for hypertension is even higher. Okay. But then most of our resources, the government, city government alone, we have spent for 100 million already. More than 100 million already. That's only for 2020. We are not yet counting the 2021. Okay. So let me share my screen. So I hope 100, how many are you? 121 medical students, future doctors, we look into and invest on the primary healthcare. So that is the beauty of the COPC, which is the community-oriented primary care. So, okay. What are some of the special features of COPC? So there is a need for a recognition of the full potential of medicine and healthcare in its capacity to promote health, prevent disease, alleviate the suffering and disability accompanying chronic illness, or cure those whose illnesses are curable, and rehabilitative, the many whose injuries and illnesses demand a change in lifestyle and work. So we have a lot right now. We just opened our cardiac rehab in EVRMC. We have the wound care and also the rehab, the primary the physical therapy department. No, for this we need a more integrated approach to healthcare than is common at present, bringing together different primary care services with certain aspects of community medicine. And we call it now COPC. For example, there is now community pediatrics. There is now in IM, there is now community medicine for internees, and of course the Department of Family and Community Medicine. What are some of the special features of COPC? COPC is a strategy, meaning it's not a pro, but it's a strategy whereby elements of primary healthcare and of community medicine are systematically developed and brought together in a coordinated practice. For example, community pediatrics will focus on the nutrition, breastfeeding, immunization. What else?
Garantisadong pambata.
Very good. GP, what else?
Deworming.
Deworming, yeah. And
School-based immunization, Doc.
maternal care, there has to be a regular prenatal checkup. What else? Facility-based deliveries. So primary healthcare addresses the main health problems in the community that must provide promotive, preventive, curative, and rehabilitative services. So COPC unites two forms of practice: the clinical care of the individuals in the community and the aspects of community medicine. So you have to take a picture of these slides. The 5 attributes that are essential to the practice of good primary care are 5. First is accessibility. So if you remember, if you are in what is the GIDA area in Catarman or in Samar, this Talalora, accessibility does not only mean the presence of doctors and healthcare workers, but also the transport. Second is comprehensiveness. Third is coordination. Fourth is continuity. And fifth is accountability. So I think the one hospital command who are meeting, they are only meeting the hospitals, but they are not meeting the municipal health officers, the city health officers, and the provincial health officers. There must be a meeting both in the those who are giving public health and also in the hospital. Why? That's why right now, I think this is 326. I already received a step down of patients, more or less 14 of them, to be stepped down to us. So that is a very good coordination in terms of where will we place the people from the hospitals, can we take care of them. So 28 plus 4, we have 32 positive cases with chronic kidney disease who are lining up there for dialysis, who is 3 times a week. However, that's only 32 from Tacloban. What about from other areas? Okay. So it's also very important is the continuity of care. So from the hospital, or from the community, from the family to the hospital, then back to the community, back to the family. Okay. So it's really about time that we have to ensure that proper care is given at the family level and community level. Another important feature of such primary care in the community is its continuity over long periods of time. Okay, eventually I will retire. Eventually I'll be out of Tacloban. But you, 122 of you future doctors, no, there must be a continuity of care. Not only that is doctor dependent, but also those volunteer healthcare workers that we have in the community. So the provision of healthcare in the community or the practice of medicine outside the hospitals is sometimes equated with community medicine. But that is not just about that. Kasi pag pumunta tayo sa community, we're thinking always of clinical. We're not thinking of the how can they what do you call this, identify herbal medicine, no, for the traditional medicine for the common Filipino family who can access in their backyard. What are these 10 approved halamang gamot, mga NDPs dati? Ano yung 10? Please answer. What are those 10 approved? Sorry, I have to. What are the 10 herbal meds that are approved by the Department of Health?
Polisimang bato.
Lagundi.
Sambong. Yerba buena.
Yerba buena is for fever? Ha? Dr. Cahiles? So, Lagundi, Yerba buena. What else? Acapulco for the fungal. Guava for the antibacterial. What else? 6 more.
Alaya.
Ampalaya for bitter gourd for diabetes. What else?
Polisimang bato, Doc.
Polisimang bato for the uric acid. Yes, Dr. Belicana. Come again?
Food.
Garlic, yes, of course, for the hypertension. 3 more. The one for toad.
Nyog-nyogan.
Nyog-nyogan is for what? Dr. Chua.
Parasitic.
Ha? Anti-parasitic is the pansit-pansitan. Nyog-nyogan is for what? And then the one, there's another one, the last. That's already in a tablet form. Huh? The one you can buy now. Huh?
Lagundi.
No, not Lagundi. The one for stone. It's also a diuretic.
Sambong.
Sambong.
Sambong. Okay, so it's complete already. 10. Sambong is for urinary stone, and also it's being used to control the hypertension for the, it acts as a diuretic. Because it's better to have sambong than a furosemide. What is the, you don't have pharmacology yet, ano? So for the furosemide, the problem is you can have hypotension. That's why you have to regulate giving of the furosemide for a hypertensive patient. So that's only one aspect of continuity of care. And at the same time is the people people in the community must understand where to get help. No? So we have to start equipping and training our local people so that they can have a network of people who can help them in their health needs. Okay. At the same time, they said that the financial access for peace, no, Pantawid Pamilya, but the problem is it becomes abuse and they don't use it for their healthcare. So we are giving how much we give for the healthcare for every family?
1,000, Doc.
Yeah. And what they are doing with 1,000, typical Filipino, they will go to, what's that, ano? They go to the groceries, but are not healthy. To, they will go to sabong.
Online sabong, Doc.
Online sabong. So attitude really matters, no? Okay, so let's continue. So practitioners of community medicine need the skills to answer the following cardinal questions. This is very important because the last week, which I am on leave for next week until Friday, we were not going to meet. You have to think of the community. So let's focus on the barangay that you are in right now, except if you are from BNG, because there are many cases. So think of another. No, we will not do this by groups, but we will do this by individual, so that it's hard in the group because of the cases right now. There are spikes of cases. So we'll just adapt a community. The first question that you're going to ask, what is the state of health of the community? Sorry, how you are going to define the state of health of the community. What are the top 10 morbidity and mortality? What is the life expectancy? What is the infant mortality rate? What is the population? What is the population among the 0 to 12? What else? What else when you say the state of health of the community? What are some of the data that you're going to look into?
Mga wara, liwat, Doc.
Aura, yes. Okay. What else?
Doc, yung sources of water kung level 1, 2, 3, parang ganun.
The sources of water, what is the source of water, level 1, level 2, level 3, or how many have access to sanitary toilet, access to health, access to safe water. What else?
Yung mga pregnants po, Doc, like,
So generally, you're going to look on the socio-demographic data. So you will start first with the general, then you go to the specifics. For example, first is the general data, the population of the community, and then you can have the population pyramid. Remember the population pyramid? And then you're going to the employment status for the health. And then there are 5 aspects: governance. What else? Completion, elementary completion rate. And then for the health is nutrition, facility-based delivery, skill-based attendance, top 10 morbidity and mortality, infant mortality rate, maternal mortality rate. Or you can even include how many in that barangay had COVID, no? And how many of them died of COVID or was hospitalized or mild, moderate, and severe. So number 2, after you presented the state of health, so you are now making a community diagnosis. What are the factors responsible for this state of health? Since kilala nyo na yung community that you're going to do the community diagnosis, you will know the factors responsible. And some of them are not even health. What are some of the factors? What are some of the factors why of the state of health of a particular community, city, country?
Prioritization of health in the community.
Yes, prioritization. Remember the SDH, social determinants for health. What are some of the social determinants of health? That was the first lecture, first or second lecture last year. What are those social determinants of health? That's life. Where am I? What are some of the factors that affect the state of health in a community? Dr. Alfred Chu, would you like to answer? You can mention a lot. There are lots. You can even obviously see it, especially next year.
Ano po, Doc, yung question?
What are the factors that affect the state of health of a community? We know that health per se is just one factor. There are still other factors, SDH, as social determinants for health. What are these factors? Can you name a few? Anybody can answer. So we can keep it going and we can finish the lecture, and hopefully the internet will not interrupt us anymore.
Government, Doc.
Yes, please.
Quality of government.
Can you expound of that?
Governance.
Quality of government in terms of what, Paul?
Okay, di ba, Doc? It depends din naman kung ano era priority. So, government yan na they prioritize more defense. So, medyo nakakadot budget. So, ito bagat. So, yan ang nagkamay ng pandemic. Medyo nagkaloko-loko ng mga unbudget since gin prioritize nila ang defense. So, nagkulang ang budget for preparation in mga sugad in na type of problems hit health. So, yan na bagat ito nagdaman utang.
So, I think even in the context of a family, if the family is not prioritizing their preventive health, we can see a lot of challenges, right? So healthy lifestyle is one. Another factor is that's political, no? When you said that prioritization in the budget, that our government prioritize defense rather than health. But when the pandemic comes, they cannot track anymore. Everything is in the. I even knew. I'm not saying it's Tacloban, no, that the money, no, some politicians are capitalizing on the COVID-19 to, you know, to get some kickbacks. So before the PPE is about how much? 3,500 or something like 6,000. Even the N95. And now in Alibaba, it's only 100 pesos. Can you see the differences how things? So economic, political, what else?
Education.
Thank you,
Education
Dr.
po.
Pidel.
Education.
Yes, Dr. Radam. Why did you say so?
Education po.
It's very good. Education is one.
Yung knowledge po ng family of how to handle yung health status ng family mismo po.
Okay. That's true, no? That's true. KAS, the knowledge, attitude, and skills that even until now in the context, even in a technological world, no, they are still believing that you should not take a bath when you have menstruation. So the cultural beliefs, no, cultural beliefs, economic, political are all contributory factors, no, in the state of health of a community. And of course, right now, in a context of a highly urbanized city, napaka-heterogeneous ng population. You don't even know who is living next door to you. Do you agree? Do you agree on that? That you don't know who is the apartment besides you. Okay, I saw a lot of thumbs up. So what is the challenge there? Before we play together, now you don't see them. They don't go out anymore. No, so they are just stuck with their. So the technological advancement is also another factor that affects the state of health. So that's why there is now an epidemiologic shift. No, so most of the cases right now that we are seeing, the morbidity and mortality is hypertension, cardiovascular diseases, cerebrovascular diseases, substance abuse. Okay, what else? Road traffic injury and suicide, no? Mental health. Okay, so because of the shift, there is we've been seeing a lot of shift in the diseases, not only in the Philippines but all over the world. Okay, so after you look into the factors responsible, but you will see the factors responsible for the state of health based on the data presented. So every community have their data, and then you can have a focus group discussion. You can do it by Zoom. No, what is being done about it by the health authorities? Toilet. Okay, our aim is zero open defecation. How many in the rural areas still defecate anywhere else? No, and you know what is the impact of that? No, so what is being done about it? Hindi nyo na mention. You were able to mention the lack of manpower, no, health manpower. Grabe, in a city with 1 million population by daytime. How many doctors do we have? We have only 3 regular doctors. That's me, Hanat, and 2 medical officers. And how do you think we can manage the public health system of Tacloban with only 3 doctors? Huh? And the number 4 is what more can be done? What is proposed and what is the expected outcome? So meaning, when you will make your COPC, you are going to do this. That is with the data and the measures that are being directed by your data. Okay. And number 5, number 4 is what more can be done, what is proposed, and what is the expected outcome. Okay. When you prepare your community diagnosis of that particular barangay, I am not concerned with the output. I am concerned with the outcome. Okay. How do we differentiate the output versus the outcome? For example, if I hire more nurses, the output is that I have 5 nurses rendering this number of a prenatal checkup 4 times a week. But the outcome that we are expecting is, does it decrease the skill-based attendance, or there are more people being, there are more mothers that is giving birth at home. So the outcome is you are addressing your objective. The the output is addressing your input. So how much you place in that, that's the output. But the outcome is what are some of the changes, although the impact you cannot see, because the impact will address your goal, no, but that is higher. So only the expected outcome. Okay. And then number 5 is what measures are needed to continue health surveillance of the community and to evaluate the effects of what is being done. After this, I'm going to send you a sample of a community diagnosis. But I want to remind you that you will not copy verbatim of that, because I know all the data that can be accessed in a particular community. So this is the, what do you call this? This is the application of all that you have learned from day 1 until this, because July is already your bi-monthly exam and finals. Okay. Any questions so far? Okay. So when you will make your intended measures, these are the cardinal features. First is the provision of primary clinical care for individuals and families in the community, with special attention to the continuity of care. For you will just place top 3 to 5 problems. The problem is malnutrition. So you're going to have a garden, no? What do you call that? Community gardens, no? For petchay, for mungo, for everything, no? So then you are going to decrease the malnutrition of children 5 years old and below. So, or suitable arrangements need to be more for consultative service, specialist care, and hospitalization. So what we're doing here in this case is that we have a health center in the resettlement area. So we connect with the EVRMC for example, for diabetes, okay? So at the community level, what are some of the things that you can do in the community level? Okay, you can do some healthy lifestyle exercise, or you can have, what we do is we have a health booklet for every family, and then at least every month, you can have the blood sugar check, okay? So you will see now if the sugar is controlled or not, okay? So another feature is a focus in the community as a whole on its subgroups when appraising needs, planning and providing services, and evaluating the effects of care. Some example of this is when you want to conduct a community plan, you have to meet with the punong barangay or the barangay council together with the barangay health workers, barangay nutrition scholar, and barangay service point officer, and show to them these are the result of the community diagnosis, and then you will plan with them, because the ownership must be in the community. These are just you are just presenting to them the need. So the community in COPC may be of any of the following in order of preference. First is a true community in the sociological sense, so one barangay, or a defined neighborhood like lahat ng mga senior citizen, okay? Or workers in a defined factory or company, students in a defined school. Okay, you would like to start a COPC project among the high school students at Tacloban North High School. Or people registered as potential users of a physician's group, just like I have mentioned, diabetes group, no, neighborhood health center or other defined service, and users of a defined service or repeated users of the service. Pwede kayo mag-start among the to start a community-based rehab among stroke patients. That is still a community. So what are some of the things that you have to take note of? First is the use of epidemiologic and clinical skills as complementary functions. Both the epidemiologic and the clinical activity should be as high a standard as possible. So the data, when you say epidemiologic activities, the data. So does everybody have at least all 25 years old and above have had their blood pressure checked, okay? And then definition of the population for which the service is or feels responsible, or the defined programs to deal with the health problems of the community or its subgroups with the framework of primary care, involvement of the community in the promotion of its health, and accessibility that is not limited to geographic. That's have I mentioned already. So at least 5 other elements can be regarded as highly desirable features of COPC, although not essential. First is the integration or at least the coordination of curative, rehabilitative, preventive, and promotive healthcare. Another is a comprehensive approach to healthcare encompassing social and mental, as well as physical aspects of health and extending to behavioral, social, environmental, and other determinants of health. So for example, we want Tacloban to be a smoke-free city or smoke-free barangay. If you see that there are lots of cases of COPD, bronchial asthma, and all these things, so you can have smoke-free barangay. And it can also be a multidisciplinary health team, mobility of the health team, such as outreach activities, or extension of community health programs beyond the framework of primary care, such as promoting health education programs in school or community centers. So one of the major aims of COPC is to remedy those unsatisfactory features of present-day healthcare, meaning curative, nakapaka-focus tayo sa curative, by integrating or coordinating the various primary care activities in the promotive, preventive. When I say curative, it's still primary care, the basic curative care and rehabilitative. Okay. So when we say clinical epidemiology in COPC, the information that may be collected includes the following. First is the demographic information on the community or the eligible population. Second is information on illnesses and disabilities. I have mentioned already, top 10 morbidity and mortality, MURA or nutritional status, immunization status. Information about health-relevant characteristics such as growth and development of children and blood pressure of the adult population. Another is information about the utilization of services and their differential use by various groups of the community. And number 5 is information about health-relevant behaviors such as cigarette smoking, family planning practices, and compliance with medical advice. Another is information about the presence of risk marked by risk factors as a basis for the identification of vulnerable individuals and groups at risk. Register may be helpful. So ito or other stressful events that may warrant the adoption of crisis intervention procedures. So just 3 days ago, I know you have read it, that a teacher committed suicide. Drink Sunrocks. Why? So she's a teacher in Tacloban North, no? Tacloban, Tigbao Diit, North Integrated High School. So we are very, very careful in the face-to-face, okay? So they had to do some assessment in the, I stop share first. They need to do some assessment in their activities. So she got infected with COVID-19. But the problem is, because we are extended family, no, Filipinos, we have extended family. She has an aunt that is with cancer, lung cancer, got infected. And another 6 members of the family got infected. So almost about 3 of the members of the family are already in the hospital. I think the sense of guilt with that patient, no, when she was, no, VNG, I think it's BNG district, I don't know a particular barangay. So I think, yeah, Both of them died on the, I think it's a lung cancer already because it metastasized. I think the primary cancer is breast. So anyway, both of them died on the same day. Pero sino ang nauna? I think nauna yata yung nagpakamatay. I don't know. But anyway, both of them. So dahil sunod-sunod every day merong nagpa-positive sa family, nadala niya yung guilt sa sarili niya. So she took her life, no? And she was not able to cope up with that. So napakarami talagang mga very important siguro if someone can use the project as mental health in the community-based mental health program on how you can do assess by a teleconsult of a person undergoing depression, person undergoing anxiety. Okay. Another is information on the performance of activities by the primary care practitioners such as screening tests, home visits. Okay, so home visit project is also another good project. Anyway, the community diagnosis that you're going to submit, no, not today, not this week, not next week, the week next week you will be using it on data gathering, on analysis of the problem. No, you use the magnitude, the severity of the problem, and then you can even have the problem tree. You can just define at least 3 problems in the community. So after that, no, you are going to submit it after finals. No, so you will have the fourth by when is the fourth bi-monthly, Dr. Balicano?
July 5 to 10 po, Doc.
Okay, that's okay. So next week will be so we can still meet another. No, you can show your progress. We can still meet two more meetings, right? We can have 2 more meetings, so we can check kasi I don't know holiday, no. We can have 2 more meetings and I will show you some of the how you can prioritize the problem that you had and some information. So you are going to use the LEPSA approach in the adult learning principles, no? Learner-centered, problem posing, self-analysis, and action. So another is information often not quantifiable on the community's interests and concerns, its demand for services, and its satisfaction with its healthcare. So pwede rin gamitin nyo ang isang project on the client satisfaction of mothers accessing prenatal care in the particular barangay. Okay, if that is a concern. Okay. So epidemiologic investigations in primary care practice analysis of the data to determine priorities for the practice. In the practice of COPC, the functions of epidemiology include first, determination of priorities on which the practice focus and the community's interest and involvement. So for example, you can now how the community is prioritizing or accessing the volunteer surveillance officers in the community. Another is the more intensive epidemiologic investigation for community diagnosis of those conditions with high priority rating, the hypertensive, the senior citizen, those with cardiovascular or the post-stroke. Or subsequent epidemiologic surveillance of the various community health programs established in the framework of community care, like TB, MDR-TB, okay, tuberculosis, or what else? Okay. And then evaluation of the programs by epidemiologic methods to measure their effectiveness in changing the community's state of health. Marami kayong pwedeng magawa in the community. Okay. The social and behavioral aspects of COPC. No less important for COPC is the knowledge that the practitioner builds up about the community. This includes important areas such as people's belief system, I have already mentioned to you, and practices and value attitudes. So even in the feeding practices, no, there is even one barangay in Tacloban that they feed their babies with ano to? Creamer, with creamer, kasi they don't have the access to ano, but we know it's physiologic that the mother will have breast milk. All they you have to do is to give them malunggay as a supplement, no, or mongo, or ano, to increase their increase their protein. Okay. And a COPC team should have knowledge of social health relevance that will not only define community health in epidemiologic terms, but also help stimulate community involvement in its own care. So at the end of the day, it still has the community to adopt the project that you are proposing. Who knows, we can use your project. I think this is my, I don't know, this is my last slides. What was so well said by George Rosen about the health officer and the community is equally for those new moving into COPC. Kasi ano na tayo eh, ganito na yung focus ngayon ng Academy of the Family Physician. A knowledge of the community and its people is just as important for successful public health work as is a knowledge of epidemiology or medicine. The first principle in community organization is to start with the people as they are and with the community as it is. Okay. So what are the processes in the development of COPC? First is the preliminary steps, community health diagnosis and health surveillance, planning of intervention, implementation, evaluation, and decision-making for future action. Okay, in your community diagnosis, you are only up to first two steps. Why? Because the planning of intervention, implementation, evaluation, and decision-making for future action should just be part, but you will not do it. But you will just have to write it that this will be the planning of intervention. You have the timeline, you have the budget, and you have the evaluation tool, how often you're going to evaluate or how often you're going to monitor. Okay. So the information needed in the preliminary steps are the community it serves and the state of the health of community. Defining the community included in a particular practice is an important step in the development of COPC in the practice. We have found useful to begin it with a relatively small defined area among, for example, teenager. When do you start the teenager? From 13 to 19. Okay, 13 to 19. So you have the general data of the community and then the general data for the 13 to 19 in that community. So what do you want to see is you want to see the behavior in their premarital sex, for example, or teenage pregnancy. So on the 13 to 19, you can check on how many of them are pregnant. From there, you are going to have now a project on different prenatal checkup among teenager. So iba yung mga kwarto, there is like something friendly, user-friendly prenatal checkup clinic. Why? Because if they go to the typical prenatal checkup clinic, they will be scared, no? Scared of the midwife. And scared of the way you're going to check them up. But if it's a user-friendly prenatal checkup clinic, at least you are going to invite them because they are considered a high-risk pregnancy. So most likely you have to make it more for them to at least have 4 prenatal checkup. So my last visit with the community, I have a patient, 16 years old, second baby already. Can you imagine? 16, second baby already. And where will they get? They're not even married. So she is taking care of her 2 kids. We thought her sister. Anyway, we have found it useful to begin with a relatively small defined area than the whole community and widen it annually until the total population eligible or likely to use the service is included. So you can even start with the practices among the hypertensive patients in the community. So maybe from 40 to 80 years old or 50 to 80 years old with hypertension. So this is it. In initiating community health diagnosis in a primary care practice, the data to be gathered should be obtained from patients' records, household surveys, and other programs of the practice such as on-site school health services and senior citizens club. The process of community diagnosis may be concerned with a broad spectrum. So if you are diagnosing a patient, you have the subjective, you have the objective complaints, and then you have the assessment and the prognosis, the SOAP for a patient. The same thing with the community, you have the subjective. So the subjective is you will have some maybe perhaps focus group discussion among this set of defined area that you want to, or a specific the 13 to 19 years old. That's a defined area. When you say objectives, these are the data that you can see in the barangay itself, in the FHSIS, no? I think every barangay has FHSIS, the Field Health Service Information System. So the process of community diagnosis may be concerned with a broad spectrum such as community health syndrome involving a number of disorders and their causal factors and effects. Or it may be narrowed down to a very specific problem. It may include the identification of high-risk groups or other groups who require special care. I already mentioned that, for example, there are lots of those with chronic obstructive pulmonary diseases, or those with patients in that barangay with tuberculosis, or the multi-drug resistant TB, and what else? Yung mga teenage pregnancy. Community diagnosis is a continuing process along with planning, decision-making, and implementation of intervention programs. So after you make the diagnosis, you have the plan, diba? SOAP. So there in the plan, you can make or these are the project that you are intending to implement. But it's not you who will implement, but you have to define how they are going to implement it. The formulation of a plan for a community program in the framework of primary healthcare will thus be based on knowledge gathered through the preliminary steps and community diagnosis that had been outlined. In addition, answers to the following questions must be obtained. Okay. First is, what is already being done about the health condition or other defined problem? If your problem is teenage pregnancy, what is the health office doing in terms of teenage pregnancy? If the problem is premarital sex, what is the HIV, STI coordinator is doing in the community? Okay. So, what is already being done by health and other services, more especially by the primary care itself and by the community itself? Number 2, you're going to ask, what can be done in the framework of primary healthcare in the light of current knowledge and practical constraints? Lalo na ngayon, we still don't know when is I don't know if there is still normal. We will not go back to normal, but we have to look into that. This is the new normal. What are some of the things we will do, no? Especially now, if there are lots of anxiety among those who are taking the modules, no? So you can have that, okay? More specifically, what are the resources of the health team for initiating and carrying out a community program? Lastly, it includes the planning of systems for monitoring progress of the program. To answer such questions, you are going to ask, are we doing what we said we would do? And is the community responding in the ways hoped for? So a lot of very good program, but they ended up, white elephant. we do some monitoring, no? So we have some lakbay aral, no? In Baguio. There's a very, very good hospital. You know what? They only use it during the COVID. It was, you know how much it costs? It's about 40,000 per square meter for the hospital, and they are not using it until there was a surge in Baguio in it's part of Benguet, right? That's the time they only use it. Okay. And I was with the Department of Health 2006, 2005, I mean. So in the implementation, the way in which the plan program may be implemented include treatment and counseling of individuals. Okay, so you might be able to have a friendly questionnaires among teenagers on what they want to hear, or what they want to if you want to go deeper on their why they are engaged into premarital sex. And then community health education and community organization with special emphasis on community involvement in the promotion of its own health. And the activities may be of various kinds. Iba-iba lang, whatever you are into when you are in your community nursing, community med tech, and other. No? First is clinical and individual healthcare in office, practice, and home calls, or laboratory and other special investigations, household visits and other group situations for household surveys, health education. Again, remember, in health education, you can use what you have used before in the in your edutainment, and then you can have it show, and then you will get the response afterwards. And stimulation of family and community interest and involvement, initiating and maintaining inter-agency functioning promotive of the community health programs, and the use of health recording procedures suitable for community analysis as well as for individual care. So when I enter in the City Health Office, I initiated the Family Health Booklet. So this Family Health Booklet, every whether a private or a public health doctor will see the family booklet. You're going to see the members of the family. You're going to see who has who gave birth, what day they gave birth, or they practice breastfeeding. Very basic on the primary healthcare. And then for the evaluation, it may be based on measures of outcome, including both desirable and undesirable changes in health status and in factors that may affect it. So for example, they are now hitting the target of at least 4 prenatal checkups, okay? Or growth, what is that? Growth standards, CGS, child growth standards, okay? And on measures that of the care provided, including the extent to which planned activities were performed and the quality of performance. So your COPC practice as a whole may be evaluated, or specific aspects as it may be appraised. So you have 12, right? Your 12 groups. Remember, you have schistosomiasis, nutrition, healthy lifestyle. You can use that, no? So, or you can have the immunization of infants and children, a program for the control of anemia or hypertension, screening for case finding of a particular condition, or an anti-smoking campaign in the practice. Last is the decision-making for future action. Following surveillance and evaluation of the situation is reappraised, and new decisions are made for continuation or modification of various elements of the program. We have implemented a COPC, Community-Based Health Program, in Palawan. You know, the one doing the smear is no longer the medtech. It's the barangay health workers that we train, barangay volunteers we train on how to do the smear, especially on the falciparum and vivax. So they are the one, a very good referral system now. So they are just given, it is, I think, awarded by the WHO during our our term there. No, until now they are among the tribal group, because it's very, very far. You have to walk 8 hours just to go to the barangay health center. So what they did is they address the mosquito control, because it's the ADs, no, Anopheles, sorry, Anopheles. Okay, so and then it's the medtech already. We provided the what they call this, the microscope, and they were the one who do the smear. Okay, so at least they are there. You can also do an anti-dengue campaign. So the community-oriented primary care report, aside from the diagnosis, is like this. No, you introduce the chosen population group and a health situationer of the said population. Step 1 and 2 of the COPC process: the data, general data, and the data specifically of the desired area. Presented the health problems identified of that which was prioritized, the same. No, actually COPC is community diagnosis. No, presented the critical analysis of the prioritized problem that led to the choice of the strategies used. So if you have the 3 problem, you're going to choose only one, and then you're going to make strategies, and then some of the strategies are service delivery, networking, organizing, what else? Advocacy, social marketing is another strategies. So from those strategies, you are making several activities, no? Presented as, and then you do the SMART objective, no? Simple, measurable, attainable, realistic, and time-bounded. And then presented how the chosen strategies or health activities were carried out. So for the results and based on the objectives of the. So for your assignment, for your paper, you're just going to, what are some intended, not yet the results. You're just going to write the intended results, no? Based on the objective. So if you have identified, for example, strategy, first strategy is dengue. For example, dengue is your chosen project. Okay, so we know that the 5S of dengue is ano. So you can teach one aspect on how the you can train capability building of the volunteer workers, in the larval survey. Diba? Yung how do they count the larva survey. So they can take the index. So if you were able to do that, that's the intended. We want to decrease every family must be aware of the larval survey. So you are going to train a certain group of people for larval survey. So what are some of the activities there? Okay, training, and then looking for trainer, and then conduct of the actual larval survey, something like that. And then presented both successes and limitation of the interventions, the resources used, and the barriers met during the intervention. Presented recommendations for future interventions. Okay, I think that's it. Any question? Naapangutana? I will send this. I will send this so you can study further. Any questions so far?
Doc, good afternoon po.
Yes.
Regarding po sa data gathering, pwede po ba kaming maka-request ng letter if we're going to ask from the barangay or from our HU para?
Yes, I can what do you call this? I can give you my e-signature. You just have to write e-signature.
Okay, thank you po.
E-sig. So electronically, yeah.
Okay, thank you.
You're welcome. Any other question? Hello, clarification?
Hello po daw. Hello po.
Wala. Wala na po ba?
Wala na po ata.
Wala na. Okay, so after this, I'm going to send the presentation so you can review it again. Is it okay?
Thank you po. Yes po.
Thank you po, Doc.
Okay, with that, enjoy the brownout tomorrow. 12 hours of brownout. 12 hours of brownout. Mamuji, miss you so much. I don't know if we will still see each other for the first time in my life. One whole year without seeing a student, only virtual.
Likely
Okay?
po ba yung face to face?
Ako ba nakikita nyo? Nakita na ba tayo personally? Siguro, not even EJ, I saw her when she was 4, I think 4 years old or 3 years old. 5, I don't know. EJ, how old are you then?
Si EJ.
Mga kuan, Doc, 5 yata.
Ayan si
5 years old. Yun lang. That's the. Of course, I saw the model of Skin 911. Yung model ng Skin 911, sino ba yan? Anyway, thank you and good afternoon. Make sure you maximize your Saturday because tomorrow it's brownout, but of course you can still maximize. Please make sure that you follow the minimum public health protocols. You will be the future doctors, the hands of the Taclobanons and other parts of Eastern Visayas. You are part of it. It's a shared responsibility. You have to make sure that you will be our advocate in allowing these people. You know, I am not really worried about, if you listen to the Facebook Live that I had through the City Information Office, don't get worried about the numbers.